In December of 2014, I had a routine physical. Several days later, I got a call from a stranger at the doctor's office who said, "You need to go to the cancer center." I looked at the phone and I said, "Why are you calling me to tell me this?" And she said, "That's what the doctor told me to tell you to do." A couple of days later, we were in our local cancer center here in Connecticut, and we met a stranger. My wife and I met a stranger called an oncologist who told us four things. One, I had an advanced case of a serious blood disorder called AML, acute myeloid leukemia. He also said he was going to prescribe a series of treatments called chemotherapy. When we were pretty stunned and asked, "Well, what's the prognosis on something like this?" And he politely said, "Mr. and Mrs. Hills, I suggest you go home and get your affairs in order." And then he said, the fourth thing he said was, "I also recommend you go to New York City to a larger institution and maybe get a second opinion." So we went home. Our life has changed. The first meeting with an oncologist is a tough family event. So we cried a little. No anger, just frustration what had happened to the family. Now, here's what I know about that meeting in retrospect, that acute is a bad cancer word because it means fast growing, that chemotherapy is a decades-old standard of treatment that at my age 71 probably wasn't going to help much for over the long haul. Getting my affairs in order was probably his polite way of saying my life expectancy had come a little shorter. And then the most important thing was, "Mr. Hills and Mrs. Hills, go to New York City for a second opinion."
Ralph, I think there are a lot of actually very extraordinary things about what you just said and about that initial meeting. And I'm curious, your take on a couple of things, because from my perspective, I don't even know how much patients are actually hearing of what I'm saying in those initial encounters. I think that it is, even when one's trying to be somewhat simple and straightforward in conveying information, just being in a cancer center, hearing the cancer word, hearing a word like leukemia, which most people don't know actually exactly what it is, but they pretty much know they don't want it and that it's something bad. I think actually it's very, very difficult to even imagine hearing or understanding or processing all of that information. And one of the things that I really think about is that, can you actually start talking about the disease and the treatment and words like chemotherapy, and all of that starts, I imagine it sounding like noise, that you're not even fully processing what the doc is saying. Do you have any thoughts on sort of, was too much information conveyed or too little, or how do we as doctors get that right in the first encounter, that we're giving you enough information and enough tools to start thinking about things, but not completely overwhelming you?
Boy, that is really the question of the moment. I have, when I hear you ask that question, the word fog comes to mind. I think I was in a fog for that moment, well, maybe from the first call, for about 3 months. I was in a complete fog. And now I can look back and I can compare going through a medical crisis the same as going through life. You know most about it after it's over.
Yeah, so I think that's very important. And fog is what I think, and I don't know, you tell me if you agree with me, but I think that even the most educated and organized patients, and you're certainly in that category of someone who's always been organized and a driver of things, you need a bus driver. And that is something which I think is really, really critical in these first encounters, is that as people are getting their bearings and thinking about what all of this means, you need a driver and you need a plan. And one of the things that I found most consistently that my patients tell me is that even when they're trying to sort through all of this incredible information, give me directions, give me a plan so that I can start stepping into what I need to do. And I think that one of the things that you were told, which is so critical to our current discussion, is to get that additional opinion and to get to a specialty center. And one of the key messages, really in anything, but in oncology in particular, is that the opportunity to have ultra subspecialized care, especially when you're talking about what is a rare disease, and AML isn't rare in my office, as you know, but it is a rare disease. It is very subspecialty management. It is not something that many centers see even a couple of times a year, but giving you that direction of, okay, you're starting to think about something as a serious problem and you've got to get yourself to a subspecialty center. I actually think that's a good initial encounter in a lot of ways, because it's at least telling you, okay, you've got to take this next step. And then hopefully when you got to me, which you did, which is why we're sitting here talking together, the key in my mind is to give people the tools to take one step in front of the other and start getting their care planning organized while they're actually getting their head around all of the information. And one of the critical aspects of AML is that sometimes you don't really have time even for this initial conversation or thought process. So AML is very, very wide in its initial manifestations. And there are patients who are so sick right out of the gate that the pleasantries of the initial conversation of sitting and taking a moment and thinking and going home, none of that's happening. I got to move. We have to treat immediately. You actually didn't have that. And I think that is a critical moment that even though AML is acute and can be fast moving, there are, for many patients, opportunities to stop, pause, think, don't launch into treatment immediately, and perhaps take that moment to get a second or an additional opinion about organizing your care. And I think as a message to the audience, that's actually one of the first questions to ask your initial treating physician, is that, is this something that is threatening my life right this minute? Do I need to start treatment tonight? Or do I have a minute to get my thoughts together and Google who is an expert in this, or ask my friend or son or daughter or somebody to help me put together who is an expert in this so that I can actually learn more before I launch into a treatment plan? And I think for you, that proved to be pretty critical, to have those extra minutes to think and to look around before you started launching into chemotherapy.
Well, it really, I have been told the luckiest unlucky person people know, and that's an old saying. But just imagine that I had a physical. I was 70 and I started to think, well, I'm starting to get a little more tired, and gee, you're getting old. And I had the routine physical. I got that terrible call, but lucky. I immediately went down to this oncologist in Connecticut. It was a very experienced oncologist. And I think what you're saying is, I was very fortunate to have the chance a week later to meet you. And that's the reason I'm still here, because I got that second opinion. But who knows, if I hadn't had the physical and I'm just starting to not even be able to stand up or something, then we're really, the acute word comes right into play. And I've learned, and this is why we're here, because it's a widespread illness, but there are not many people that know how to treat it. And you have to get to someone like you.
So in medicine, we like to say, and we learned this a long time ago, that when you hear hoofbeats, don't think of a zebra, think of something more common like a horse. And I think the point is that when there are signs and symptoms of things like shortness of breath or decreased energy level or looking and feeling pale, one doesn't immediately think, of course, of a leukemia diagnosis. There are many, many things that can cause those types of symptoms, and leukemia is a rare disease. However, signs and symptoms of bone marrow failure include things that are related to blood counts. For example, if the white blood cell count is very low, or if there aren't good infection-fighting cells, One may have infections, and sometimes people will present with bronchitis followed by sinusitis followed by pneumonia, and they'll say, but I have never had an infection in my life. How come I've had 3 in the last 3 weeks? That can be an early sign of a bone marrow problem. Similarly, if you're normally running up and down the stairs in your house and vacuuming and doing 10 loads of laundry, and now all of a sudden you can't do any of that, that can be a sign, again, of bone marrow problem, of failure of the bone marrow to produce red cells. Red cells carry around your oxygen and give you energy, and anemia can present as shortness of breath, fatigue, loss of exercise tolerance. Platelets are little tiny cells that help you clot if you get a cut. And sometimes people will say, I've never had a nosebleed in my life, and now I've had 5 nosebleeds in the last week. What's going on? Why am I having excess bleeding? So the signs and symptoms of bone marrow failure are something that can be elusive, but that may be picked up by the doctor. And that's why going in and getting checked out and having initial blood work is such a key element for the early diagnosis of AML. Once you have a CBC, or a complete blood count, which shows abnormalities, typically that will result in referral to a hematologist, who will then sort out whether a bone marrow biopsy is needed or whether adequate information can sometimes actually be obtained from the peripheral blood. And the diagnosis of AML can in fact be made from peripheral blood, although bone marrow biopsies are typically performed. And that involves a complex series of laboratory testing, including mandatorily cytogenetics, next generation sequencing, and flow cytometry. And these are complex laboratory tools, but which put together a diagnosis of AML, and actually then further information from cytogenetics and from molecular genetics that allow risk stratification. So is the disease going to be easier or more difficult to treat? And then potentially targeted therapy. Are there aspects of the biology of this particular AML that will allow us to apply specific agents in order to best treat it? And that, I think, is the whole kind of diagnostic package of what's needed to get somebody from the initial symptoms to a complete diagnosis of AML. So here are maybe some take-home points from this aspect of kind of AML care and of your experience that I think are very, very valuable to kind of summarize and put together. So the first thing is, don't blow off signs and symptoms of things, and don't assume that if you're tired or short of breath or having new symptoms that you're just getting old. And I would say in particular during the pandemic, there has been a lot of misattribution and blowing off of symptoms, because for the last year, every time somebody has a cough or feels short of breath, the only thing that's being thought of is COVID. Get yourself checked out. Physical exams are important. There's a reason they're done routinely. If you know yourself and you know your exercise tolerance and energy level, and it's not what you're used to, get it checked out. That's just general good management. And don't let anybody tell you, you're getting old, because that is probably actually not the right answer most of the time. Once you get a diagnosis, in your shock and horror of the diagnosis, you want to think about a couple of initial questions, which is, first of all, is this something that I really need to treat right this second? Or do I have a minute to get organized in my thinking? And you always do want to try to get a level of expertise. Try to talk to the doctor that you're working with. That is this something you do every day and see every day? Or do you know somebody who does this every day? And to be honest with you, what I find is that most doctors are incredibly willing to defer or refer to experts when it's an area that they may not know that much about. And acute leukemia should be treated by an acute leukemia expert, at least in consultation. There may be opportunities for clinical trials or novel therapies that are different in one center versus another. And I think that collaboration and communication among doctors is so important and so readily achievable, and may even be better now in the times of the pandemic, now that we are all used to Zoom and video. So get the exam, get checked out, find out if you have a minute to think, and get some expert consultation, I think would be the key take-home messages from your initial experience.